Ethics and biotech?
No, that was advanced writing.
I'm gonna do first.
Sounds good.
Oh, we have to take a class for that. You have also like how long?
All right. Good evening, good afternoon, and welcome. Welcome to all of you. Just a few rules of the road, so to speak, friendly rules of the road to get us going here. So we're going to have a break after Elsa's presentation. So we'll have a little 5-minute or so break. The presentations, we're going to have a little timer. So Sydney's going to hold up the 1-minute sign when you have 1 minute to go. And all. So really, we're going to keep on time, wrap it up, 7 minutes. And that also gives us a chance to have a question posed. So I really, invite you all, really think each of you have done so much good work this year. And all of your peers, just listen closely and, we'll kind of try to get like one good question for each presenter posed by, I trust, one of you. To your colleagues. That'll be just great to open up a conversation. Unfortunately, we can't let that go too long because we want to keep things moving, but that would be great to do that. Also, there's chocolate there on your tables, food for the journey to help you just get through the next few hours and keep the energy level up. So, all right, Sydney. All right, so welcome to the 2024-25 Healthcare Ethics Internship presentation. And it's just so great to have you all here. This is such a great event every year. The Healthcare Ethics Internship is a wonderful program of the Ethics Center. I've been here for 23 years. It predates me in its previous iterations. And I have seen generations of students, like literally now, who have benefited so much from this program, the exposure to kind of a hands-on engagement with medicine in many different dimensions, and reflecting on ethics in kind of a real-time way and carrying that forward in your life, in the medical professions or in whatever you're going to pursue. So a wonderful program and a wonderful leadership in the last years by Dorothy Caminiti, our dear colleague who has had to leave this year due to some family matters. But we miss Dorothy very much and are so grateful for her leadership and mentorship this year. The Healthcare Ethics Internship qualifies for the Experiential Learning for Social Justice core curriculum requirement. Always good to know about that. And it features weekly discussion-based classes in which students focus on ethical dilemmas in healthcare and medical technology, and also bring in guest speakers who have a lot of experience in the medical and healthcare field. And includes really indispensably this community-based experience involving rotations at Palo Alto Foundation Medical Group and Sutter Health institutions. So really being in hospital, clinical, and other settings. The blog posts of all of our terrific students here tonight are up at this link, and you can go see them there, but even better, you can hear the wonderful presentations here tonight. All right, so we're going to get right after it here, and we will start with a presentation by Sydney Shelby, the Hansel Fellow this year at the Markkula Center for Applied Ethics. Sydney is a senior public health science and biology major and an African American studies and medical and health humanities minor. And her topic is Laboring for Change, a conversation on the Black maternal health crisis in America. Sydney.
Thank you. Hello, everyone. Good to see you all. I'm just going to get right into it. So we are so lucky to be living in the same timeline as Serena Williams. Not only is she an incredible tennis player, but she is undoubtedly one of the greatest athletes of all time. Not to mention the challenges that she surmounted being a Black female athlete in a predominantly white sport. It means that her $350 million net worth that she had accrued is even that much more well-deserved. But my presentation tonight is not about how much I love Serena Williams, though I do love her. It's about how someone like her, with her wealth, her status, and her access, ends up in a situation like this. In 2017, Serena gave birth to her daughter, Olympia, and her pregnancy was relatively normal. There was little complication, and the only big change that happened was when she went in for her induction, and she ended up having a C-section instead of a vaginal birth like she had planned. The real story doesn't start until after she's out of the operating room, and she's sitting in her bed, feeling like something is off with her body. Serena had a history of blood clots in her lungs, and so she knows that that means that she needs to monitor that very carefully to ensure that those blood clots don't travel to her heart, because that would cause her to have a heart attack. And so she was very vigilant about this during her whole labor. And when she started to feel slightly off, she was quick to notify her care team, telling them, I really think I need to start my blood thinner medication to ensure that this does not escalate. However, she was met with, no's and defiance and, you don't know what you're talking about, you just gave birth. And so the situation progressed so much so that she was coughing so aggressively that her C-section scar actually tore. It wasn't until after this that she said to a nurse, square in the face, "I feel like I am going to die if you do not give me a CAT scan right now and start me on my blood thinner medication." And the nurse said in response, "I think your medicine has made you feel a little bit crazy. You need to get some rest," which is insane. And finally, after enough bargaining with her care team, she was able to convince them to do her CAT scan. And lo and behold, she had blood clots in her lungs, and one was very close to her heart. Unfortunately, Serena's story is not unique. Though the United States is one of the wealthiest nations in the world, it has a very real problem when it comes to its maternal morbidity outcomes. And these impacts of these outcomes are not felt equally across all races and ethnicities. As you can see from the chart here, Black women are more likely to die in childbirth than any other race or ethnicity, and on average are 3 times more likely to die compared to their white counterparts. In public health, we have something called the social determinants of health, and they help us to understand health disparities like this. They often look at things like how your education level or your income or your ability to get to and from the doctor might impact the quality of care that you receive. However, this crisis doesn't follow the typical schema that we see for most health disparities, in that income actually is not everything here. We see it's well documented that even the richest Black mothers have a higher infant mortality rate than the poorest white mothers. And it really draws into question how people like Serena Williams, who have access to the best doctors, nurses, pre- and postnatal care, can end up with such a horrific situation like she found herself in. And to me, it boils down to 2 factors. The first being the legacy of the awful start of the field of gynecology and the impact that has today. This image is an artistic rendering of J. Marion Sims, who is deemed as the father of gynecology. And he was revolutionary in helping to standardize the field, and he came up with a lot of surgical procedures that were really instrumental at the time. But his success was completely built off the backs of enslaved women that he used as experimental subjects. Additionally, if you think about Serena's story, we can point to the discriminatory practices that were dealt by her nursing staff and her care team. Implicit bias is a really big part of that, and that does have roots in our past of slavery. There are healthcare providers that genuinely believe that Black bodies feel less pain than white ones, and so it's no wonder that you have Serena's nurse telling her that she doesn't know what she's talking about, that she doesn't know the pain that she's actually experiencing. And so these are really big challenges that we continue to grapple with in academia and as we look to how we educate our medical professionals. But one thing as I came into college, I started thinking about, having experienced situations like Serena's through my own family's eyes, was how those theories and methods for understanding these crises don't get really disseminated to the public in an effective way. And this was something that I think could really be a point of empowerment for a lot of communities, could help to contextualize their struggles and see that they're not alone in their suffering. And so this was kind of the jumping off point for what would become my Hansel Fellow project. As I looked to different community organizations who are doing this work to educate and empower Black birthers to strive for the best care possible, I stumbled upon the Black Mamas Matter Alliance, and they were founded in 2016, originally to uplift the struggles that Black women in the South were facing with accessing maternal health care. But they have developed into this national organization comprised of many community-based organizations, as well as Black professionals who help to try to fight this crisis, both before pregnancy happens and after it happens as well. And one of their initiatives is Black Maternal Health Week that they started back in 2016, which happens every April 11th through 17th, as a way to really center the discourse on this crisis and make sure it's a prominent part of the conversation in public health, medicine, and importantly in policy. And so for my project, I decided to plan an event in accordance with this week. And so I was blessed enough that this past April, I was able to bring a dialogue to our campus that would really center this discussion and allow for students and community members to have an opportunity to critically think about the crisis and how they could maybe combat it. Something that was really important to me in developing this event was the fact that it needed to be interdisciplinary. In all of my studies in college so far, I feel like I've learned that research and medicine are not done nor practiced in a silo. And that, policy and society and our beliefs and values and opinions do impact the way that researchers do research and that physicians practice medicine. And so it was important to me that I brought in people who could honor different perspectives from different fields as to how they were approaching combating this crisis, and then how we could bridge those interdisciplinary solutions together. And so I was blessed enough to be able to bring in 3 speakers to my conversation that I hosted on campus. The first was Dr. Eleni Halu. She is a PhD, getting her PhD, or postdoc at Stanford. And she has a PhD in public health, and she does a lot of work looking at the social determinants side and how that interacts with care. Dr. Aroke Ijbenosa, she is a maternal fetal medicine doctor, and she does a lot with looking at community-based interventions and prenatal care, and so she was going to represent kind of the medical side. And then Miss Sarah Murphy, representing Maven Clinic, who is an insurance provider, helping to connect women to different providers across telemedicine. And so I'm very blessed to say that the event was a success. Many of you in the audience today were there, and so thank you so much for coming. I think it was a great success, and I feel really good that we were able to have a great student turnout, and hopefully people were able to glean some takeaways from the event overall. And so again, thank you to not only all of you who were there, but to the amazing team at the Markkula Center, who I could have not put it together without. So all of you know who you are, but thank you. And I did just want to share a couple of the takeaways that I feel like I really gleaned from the event overall. The first being the influence of neighborhood factors. So although it is well documented that this crisis does not bear in mind class, it is still important to consider how class issues can impact someone's ability to access care. And we do see a big overlap between communities that have been redlined historically and maternal health care deserts, which are places where women are not able to find adequate health care for pre or post or during their pregnancy. And so one of the things that came up was how companies like Maven are able to use different technological advancements, things like telemedicine and AI, to help connect women that might find themselves in these maternal health care deserts to providers that look like them and that they are comfortable with. The next thing that was a big takeaway, which as evidenced by my speech about interdisciplinary collaboration, I was happy about, was the need to really center in a collaborative network between all of the different players in the healthcare system in combating this crisis. One example that came up was Dr. Halut spoke about how it's hard for her to be able to effectively do research on this crisis when she has such limited access to patient health records and things like that. And that comes at the leeway of health systems as well as insurance providers. And so they all need to be on the same page of how important it is that they work together to establish and find ways to fight against this crisis. And so that was a big takeaway that came through as well. And the last one was just the importance of using our voices and our votes to fight against injustice. A big conversation was certainly had about the impact that the federal government is having on a lot of the work that's being done in this field right now. But as important it is that we vote to make sure that those federal positions are filled with people who care about this, it's also important that we pay attention at the local level and get invested and involved in our local and state governments, ensuring that those seats are also held by people who realize how pertinent and pressing of a crisis this really is. And so that burden lies on all of our shoulders to stay informed and to pay attention to what is going on. And to wrap up, I just wanted to conclude with talking about, my interest is in this crisis certainly intersects, with my identities and my interests in public health. But to me, it really answers this fundamental question of who has the right to exist in the world. I think that the way that our society continues to answer this question with our policies, the way that we provide healthcare, really reveals whose lives we place value on and whose we don't. And so I don't think that there's a more pressing or important question to answer, and I see this crisis as an avenue to that. And so I would like to end my speech the same way that I ended my panel, which is with a quote by the great Toni Morrison, which is, "When you get these jobs that you have been so brilliantly trained for, just remember that if you are free, you need to free somebody else. If you have some power, then your job is to empower somebody else." Thank you.
Thank you so much, Sydney. Team, question for Sydney. Please.
Thank you very much. Sorry, Sydney, I just have a question regarding, what are some of the most common, maybe, pregnancy complications that Black women tend to face? Thank you very much. I understand there's a lot, and thank you very much for the beautiful presentation.
Yeah, of course. There is a lot. You are right about that, but definitely there's some really big contributing factors. I think one of the major ones is postpartum hemorrhage. So Black women have a much higher rate of postpartum hemorrhage. That's be after they give birth. So kind of similar to Serena's case, where she had a complication post-birth. So that's a really big thing. So just making sure that after the delivery has happened, that Black mothers are still being taken care of and being paid attention to. Also, Black women are more likely to have poor mental health outcomes pre and postpartum. And so I think that that's another really big thing that the conversation is starting to be had about, of how can we better connect Black mothers to good prenatal services, but also doing the necessary follow-up on the postpartum side to ensure that they're getting the support that they need.
Thank you very much, Sydney. I appreciate it. Thank you.
Thank you so much. All right, Sydney. Let's give it up for Sydney. All right. Our next speaker will be Tianyu Tan, a junior biology major, and will be speaking on the topic of your money or your life, the ethics of the expensive rabies treatment. Tianyu, please. Can we have the clicker?
I just put it right
there. Okay.
Thank you very much, folks. Thank you. Thank you very much, sir. Appreciate it. Thank you. Hi, good evening, folks. So tonight I'll be discussing your money or your life, the ethics of expensive rabies treatment. First of all, I know that a lot of you may have seen movies where there's like this bad guy that suddenly comes out and says, "Hey, bro, your money or your life," and that's obviously very scary. But you can always just turn that TV off, and then you can just try to forget about how it traumatizes you. But sadly, for some people, especially those who are attacked by rabid animals like cats, bats, dogs, raccoons, or coyotes, this is a harsh and horrifying reality that they can't just run away from. So let's start with two stories. So it all started in Keene State College, where a student named Allie McNamee was just chilling in her own room, and she suddenly saw a huge bat come in and then bite her on her hand. And meanwhile, a woman in Orlando named Sabrina Bathwick was just hanging out in her backyard, and she was just walking around, and then she saw a cute little kitty and pet him, and suddenly the cat just bit her hand. And now both of these women had to go to the doctor. And while some people would say, "Oh, it's just a cat, it's just a bat, it's such a cute little animal, what harm could it cause?" But that's where the scariest part is, because all of these animals, the bat in Allie McNamee's story and also the cat in Sabrina Daswick's story, they can all carry a disease called rabies. So what is rabies? And here I've created a diagram showing the symptoms of the disease. So right after you get bitten or scratched by a bat or a cat or whatever animal, like at the beginning you feel no symptoms, like everything just goes on as normal, everything's peaceful, and suddenly one day you get a little headache and you suddenly feel a little tingling at the butt, or maybe you have a backache, and then suddenly you feel, oh, my throat hurts, and then you suddenly start feeling chills and you lose your appetite. And now you might think, oh, it's just like a regular cold, what's so bad about it? Except it gets worse. Eventually your symptoms evolve into hallucinations, and eventually you lose control of your emotions. Like everything that used to make you happy doesn't anymore, and you find yourself becoming scared and angry at everything, and you don't know why. Right? And that's because the rabies virus is actually just pretty much destroying your brain and messing up your sense of reality. And you also suffer seizures and insomnia. And then there's this extremely terrifying symptom called hydrophobia. So think about it. If you're thirsty, you can just get a water bottle and drink the water. Except that now you're still thirsty, but now the rabies virus has hijacked your brain. So now whenever you even think of water, much less like come near a bottle of water, like suddenly your throat just clenches shut painfully. Like it just every time it's just like this. Like you feel thirsty, you try to get water, and your throat clenches shut, and you have another seizure, and it's just terrible. And eventually, after weeks of having severe seizures and horrifying hallucinations and not being able to sleep for a single second, and feeling thirsty but being unable to drink without having painful throat spasms, and like you fall into a coma and you pass away, and it's 100% of the time. So yeah, it's not a fun disease. It's super scary. And worst of all, this will happen 100%. Like if you don't go to the hospital and get the life-saving treatment or the post-exposure prophylaxis on time, like there's just this window like between when you're bitten or scratched by the little bat or the raccoon and when the first symptoms show up. Like you have to get the rabies vaccine and the immunoglobulin and like inject it into you, or else this will happen 100%. So of course, Allie and Sabrina had to go to the doctor, and they had to go get the rabies vaccine. Bless you. Oh, and the worst of all, later their medical bills came out, and they had to pay at least $6,000 for the vaccine. For Allie, the treatment costed around $6,000, and for Sabrina, it costed around tens of thousands of dollars, and they had to pay it if they were to get the treatment that they needed to avoid a fate like this. And And that is just absolutely unfair because now these poor people are just forced to choose between paying such a large amount of money and dying in such a painful way. Hey, and all because the healthcare system in the US is just so unregulated. Like prices can just go to like thousands of dollars and tens of thousands of dollars just because two people don't want to suffer such a excruciating death. And some may say, why is this so expensive? Well, okay, so the reason why the treatment is so expensive is mainly because of the rabies immunoglobulin, which is supposed to help your body develop antibodies. So first of all, it's collected from human blood. Like they find a willing human blood donor who donates their blood and their plasma and their antibodies, and then eventually the blood is purified, which takes a lot of work, and eventually after the purification, it can be used as a vaccine and injected into the person who needs it. And now that's just really unfair because think about it. Even though it surely benefits the researchers who are in charge of producing the vaccine, think of the person who gets bitten. Like they don't just go out there and choose to get bitten and attacked by a little bat or a raccoon or whatever. Like they now have to be choosing between like paying a lot of money and on suffering a painful death. So it's basically pretty much saying to them, if you cannot pay, then we'll just leave you to suffer. And that's very, very maleficent. That's causing evil. And also, it just infringes upon autonomy because many people will have to be forced into unsanitary and dangerous jobs in order to pay for the vaccine. And it's also unjust. Thinking of just the wage gap in general, like just think of people, especially Black women, Indigenous women, and Latinas who are unable to make as much money. And they still have to pay so much just for the treatment. And it's just not just for them that they cannot receive the life-saving care just because they can't pay for it. And so far, it's very hard to change a system like this. Like the best we can do is just try to educate each other on like trying to prevent such bites in the first place. Like we just have to try to teach the little kids to not go out and pet the random cute little kitties or doggies. And also, we may be students, but we should call our representatives because after all, they have the power to change the system. And I know that it's easy to feel pessimistic and like the system will never change, but we need to try. We need to speak up. And when we speak up, like about how deregulated and just how messy the system is, like just charging so much for a life-saving shot, we might be able to teach this old dog of healthcare system some new tricks. And thank you very much for attending my presentation. Thank you.
Thank you so much, Tianyu.
Thank you, sir.
Question for Tianyu. Please, yes.
Thank you.
Thank you for your presentation.
Oh, thank you. That's so kind of you.
I was just wondering, is the rabies treatment, I guess this is just like a reflection of how little I know about rabies, but is it a preventative like vaccine or is it like a post-exposure?
Oh, it's like post-exposure. Like you go outside, pet a dog, and the dog bites you, and then you go get the shot. And you have to get off it or else it cannot work. Thank you very much for the question. Appreciate it. Thank you.
Thank you.
All right, thank you so much, Tianyu. Oh, fantastic. Thank you so much, Tianyu. All right.
Oh, just make sure you grab this.
Oh. All right, thank you so much, Tianyu. Our next speaker will be Tatum Holloway, senior biology major and medical and health humanities minor, speaking on the topic menstrual equity, ethical responsibilities in access and workplace accommodations. Tatum. Can you use that?
All right, is it working?
Yes, it is. Right.
All right. Good evening, everybody, and thank you for being here. I'm Tatum Holloway. I'm a senior biology major with a minor in medical and health humanities, and I'm here today to talk to you about an issue that affects 1 in 4 people globally, but is still surrounded by such strong stigma, and that is menstrual equity in the workplace. So, in 2020, a warehouse employee anonymously spoke out in a news report. She reported that while working on the warehouse floor, she bled through her pants due to inadequate access to a restroom, and when she brought this up to her manager multiple times during her shift, she was dismissed every single time, and she ultimately left her shift in humiliated and also in physical pain. Throughout my research on this topic, stories like this were not few and far between. Workers, and especially those in low-wage paying jobs, are stripped of their basic health needs. And so adding this issue to the stigma surrounding menstruation, the issue just compounded that much further. So before we talk about the solutions, we got to talk about the root of the problem, and that's period poverty. Period poverty is a lack of menstrual access, education, and wellness spaces for those that menstruate. And a shocking stat reported in 2023 by the World Bank said that out of the 1.9 billion menstruators globally, at least 500 million of them experience period poverty. And when looking at this other graph, the numbers show that the average American spends at least 2,000 hours a year at work. So putting these numbers together, it just becomes much more clear that menstrual equity in the workplace is not simply a hygiene issue. And to really dive into why this topic is very important, I think it's helpful to look at one of the leading voices. This is a quote by Jennifer Weiss Wolf. She's an attorney and an author, and the U.S. News Weekly actually called her the U.S. architect to squash the tampon tax. And I love how she puts it so simply and bravely into one sentence by stating, menstrual equity is a cornerstone of gender equality. Without it, we cannot claim to have truly inclusive workplaces. And I love how she's bringing up the topics of menstrual equity and inclusion, and that is exactly why I decided to tackle this topic today. So now let's talk about the real cost of menstruation. And I'm not talking about the dollars, I'm talking about the consequences. A shocking study conducted in 2019 stated that at least 64% of low-income women in St. Louis had to decide between paying for food for their family or for menstrual products at least one time during the year. And here's the kicker. Tampons in most states in the United States are taxed as luxury items. Yes, I said luxury. That means in states such as Texas or even Georgia, your tampons are taxed, but things like candy bars or even Viagra are not. And advocates of the tampon tax, people that want to repeal the tampon tax are advocating that they unjustly inflate the cost of essential health products for those that are already disproportionately facing economic hardship. And the fact that this is happening in one of the richest countries in the world really begs us to ask the question, how can we say that we value equity and equality here when there are those in the United States that are being penalized for simply menstruating? So, it's super clear that menstrual equality in the workplace is far beyond a personal issue and has real health and ethical implications when ignored. A startling stat that I found while doing my research actually comes from John Gulabad, a reproductive health expert who likened the symptoms of period pain to that of a heart attack. Yet, menstruators are still expected to power through their workday and still having the stigma surrounding them that does not allow them to advocate for themselves and speak up. And while there are some companies that have menstrual leave or menstrual policies, it's clear to on this graph that there are still disparities at hand. Looking at the graph, 57.6% of menstruators, especially those with severe period symptoms, wanted to take menstrual leave but never did, really highlighting the gap between policy and practice. And this reluctance here has real consequences. The consequences being that menstruators who worked through menstrual symptoms did lose an average of 8.9 days of productivity annually, compared to just 1.3 days for those who could actually take menstrual leave. So with this, justice is completely ignored as they are not given the same support in the workplace. Beneficence is not upheld as their health needs are being ignored. And autonomy here is being compromised again because the stigma does not allow these menstruators to advocate for themselves in the workplace. But the best part, it doesn't have to be like this. Companies in Indonesia and Japan actually are legally required to have menstrual leave. And a social enterprise company called Coexist in the UK actually implemented what they call their period policy, which allows wellness spaces, menstrual leave, and open dialogue at work. And with that, employees there actually reported being more productive and feeling more valued in their workplace. And lastly, we have the Victorian Women's Trust out in Australia, who implemented a very similar policy as Coexisted. And with that, 75% of their menstruating employees responded that they felt more respected and valued by their employers at work. Thus, it's possible. And this is what it looks like to have dignity over deadlines. And the best part about it is that it's effective. So we've looked at the realities, we've looked at the data, and we've seen what happens when we ignore menstruation in places like school or the workplace. But the best part about it is that the truth is that menstruation doesn't stop at work, and our policies really shouldn't either. If we really want to create truly inclusive workplaces where everyone feels empowered to do their best work, we must move from awareness to action. And that looks like implementing free menstrual products in the restrooms, just as you would see hand soap or paper towels, allowing flexible sick leave that really acknowledges period discomfort, abolishing the tampon tax and reclassifying tampons as essential health products, and integrating wellness spaces and open dialogue in the workplace. And lastly, integrating menstrual health in HR training. None of these ideas are radical, and I promise you the best part is that they don't just benefit menstruators, they benefit everybody. So whether you're a coworker, manager, or someone with a voice, you do have the power to change this, because I would like to end this by saying menstrual equity is not just a woman's issue, it's a human rights issue. Thank you.
Thank you so much, Tatum.
Yeah, open for questions.
Please. And in the back as well, if people have
Questions or comments are appreciated. Oh yeah.
please.
Have you seen any progress in this area in the last 10 years, 20 years?
Great question. The question was, have we seen any progress in the data in the last 10 or so years? And I think, like I mentioned, we are in a stage where we have a little bit of awareness around the topic, but we haven't moved, in my opinion, to the action stage. So looking at the data, I saw that there were things that were implemented and some things didn't work. But I'm seeing that it's the beginning of these types of initiatives, which I find very promising. So I think that in the next 10 years, we'll definitely see some progress. But through my research, the past 10 years we haven't moved too far, but I'm very certain and hopeful for the future. Thank you.
Let's give it up for Tatum. All right, thank you so much, Tatum. Our next speaker will be Matteo Fesselmeyer. Matteo is a junior biology and biology major, public health minor, and he will be speaking on the topic fair play or an unfair edge, navigating the ethics of sports enhancement. Matteo, please. There you go, that one and that one. Thanks.
So my name is Matteo Fesselmeyer. I'm a biology major, and today I'll be talking about the ethics of sports enhancers. So what are sports enhancers? You know, probably most of you, when you picture sports enhancers, you think of something like the image on the left, anabolic steroids, an athlete taking a drug to jump higher, run faster, go for longer. Well, what if I told you that sports enhancers include a vast array of methods, from technologies to equipment to even gene editing technology? More on that later. One example that I like to bring up is the Nike 4% shoe. It's a shoe designed for distance runners, and it helps them run for longer and use up less energy when racing. So recently, the NCAA banned the shoe, and this is a shoe that I've personally used in the past in high school and throughout the early part of my college career. And I think that this is a fair decision just because different schools are sponsored by different brands. Here at Santa Clara, we're sponsored by Nike, but another school like the University of Washington is sponsored by Adidas. So not everybody has the same access to the same technology. And this creates disparities in the world of sports, especially distance running, but other sports like cycling and football and like tennis, that kind of thing. So why is this an issue? Well, it all comes down to fair play. Well, what exactly is fair play? Well, fair play is the equal chance for everybody to win due to inner characteristics such as skill, effort, strategy, how much you want something. Usually with fair play, you exclude external factors like sports-enhancing drugs. Now, there are people out there that will say, well, maybe sports-enhancing drugs are a good thing. We want our athletes to run faster, to perform better, because that has an entertainment value. Well, I say that's kind of like a secondary purpose of sports. The primary purpose of sports is to build character, to push people to the limit of human capabilities, not to surpass human capabilities, but really just to find the edge. Therefore, fair play is something that we need to elaborate into our sports and make sure that it doesn't become blurred. With doping, there's a vast spectrum. One example I want to give is with blood doping. Let's say me as a runner, if I go to train in Colorado, which is at an elevation, my hemoglobin levels are naturally going to go up after 3 weeks. Now, if I train here in the Bay Area, which is at sea level, and take EPO, my hemoglobin levels are also going to naturally rise up. Both are forms of sports enhancement, but one is legal while the other isn't. Ultimately, where do we draw the line? Now, who here has heard of Lance Armstrong? He's a pretty famous guy, right? He's achieved the pinnacle of road cycling. He's won 7 Tour de France. Tour de France is like, are you kidding me? Like, that is, to me, the pinnacle of sports. But he's so well known for all the wrong reasons. This guy cheated for so many years, and he inspired so many other people to cheat. And what's worse, the people that came after him, the people who finished second and third place, they lost that recognition because of him. Ultimately, his selfish decision-making is what caused the integrity of cycling to take a hit for many years. And it's not a unique issue to the sport of road cycling. It's occurring in sports all over, and not just by individuals like Lance, but by sports organizations overall. Take, for example, the Russians. They've been cheating for years. You're looking at like the 1980s, 1990s, 2000s. It's really a doping scandal, and it's not just in Russia. It's all over the world, but it's very well documented in Russia. Here we have Kamila Valieva. She was 15 years old, competed at the Winter Olympics, but it was discovered she was taking a sports enhancing drug, and she was subsequently banned. This is not the first instance of a Russian figure skater being banned. There has been 3 other instances, and they were all under 19 years old. These athletes were pushed by their coaches, they were pushed by their organizations to take these drugs, and the result? Their careers got cut short. I mean, the 3 people that came before her, they all retired at the age of 21. These are girls that had like their whole lives ahead of them, and it was cut short by sports enhancements and the desire to win at all costs. Now, I was going to mention gene editing technology. Current gene editing technologies like CRISPR, which allow us to make genetic enhancements, can tarnish the future of sports. This is because they improve physical ability. They allow people to recover faster. For example, they could help improve muscle fibers, and they could strengthen muscle fibers as well. And they really ruin what we think of natural talent. Now, when it comes to natural talent in sports, I like to think of it like poker. Who here has played poker? A lot of people, So in poker, you don't need a royal flush to win. It's all you can win by bluffing, and that's kind of what sports is. You don't need to be the most talented person to win. It's about playing your cards right. You know, when I go out there and compete, I'm not the best, I'm not the most talented person on that track, but I'm going to do my best to win. So when it comes to natural ability, it's kind of like that. Everybody has a different level of natural ability, but it's about using the right strategy to win. And with CRISPR and these genetic editing technologies, it kind of ruins that. So what are the consequences? Well, the enhancements damage the integrity of the sport. It's no longer about using strategy to win. It's more about who has the resources. Fans lose interest and athletes lose motivation because of that. I'm not going to go out there if I know that a guy is going to just simply beat me 10 out of 10 times. But if there's a 1 out of 10 chance, I'm going to go out there and try and win. Sports enhancements also have long-lasting health effects. Things like blood doping affect your heart, and people that are known, or athletes that are known to be the pinnacle of health, have suffered from health issues later down the road. Ultimately, victory loses its meaning. Where do we go from here? Well, we can support world anti-doping organizations like the World Anti-Doping Agency that seek to test athletes and make sure that no one's cheating. And also as athletes or people that enjoy sports, we can create we can design the world we want to see, right? So sports are what we think they are, and yeah, that's all. Thank you very much. Yeah, questions?
Thank you so much. Question? Yes, please, Tianyu.
Thank you very much. So, basically, I'm sorry it's a silly question, but I heard that some like sports enhancement stuff can actually be like natural stuff on the body. Let's say testosterone. I heard that some people have higher testosterone levels than others. So let's say if two people are competing, and then one person naturally has higher testosterone levels than the other person, and the other person with less testosterone tries to take testosterone, so it will just level the playing field. Would that still be doping? Sorry, it's a silly question. Thank you.
Interesting question. Well, there was an instance of that. I remember Caster Semenya a couple years ago. She was a South African runner who competed in the women's division and had higher levels of testosterone. Unfortunately, she was banned. I think that is kind of unethical, just because she is a naturally born woman. You know, she should have the ability to compete. Ultimately, I think it comes down to natural ability. Obviously, like I said before, some people have higher natural ability than others, but that's not the determining factor in sports. The determining factor is how you play the cards, how you choose to strategize and win. So I think that, instead of making testosterone or like hormone levels the pinnacle of sports and designing it to fit with what we believe is fair, it's more about understanding that it's only a piece of what allows an athlete to win. It's not the deciding factor.
Great. Thank you so much, Mateo. All right. All right, thank you so much, Mateo. We're off to a fantastic start here. All right, our next speaker is Sarah Harrington. Sarah is a senior biology major, and she will be speaking on the topic, The Evolving Ethics of Pediatric Care, Balancing Consent, Autonomy, and Protection. Sarah.
Awesome, thank you. No.
You got it.
Yeah, okay. Thank you for the introduction. So my name is Sarah Harrington, and today I'm going to be talking about how pediatric ethics has evolved, and I'm also going to be assessing the guidelines in order to provide the best care for the youngest patients. So as we've touched on so far in the previous presentations, and as we'll continue to talk about, ethical decision-making is... Did I just click the button? Oh. I just clicked the button. Sorry.
Okay, perfect.
Is that what you want?
And go back. Perfect. Awesome. Thank you. Sorry. So, as we've heard so far, ethical decision making is a cornerstone in providing good care for any patient. But in pediatrics, it's especially complex with the addition of parental involvement in decision making. And so, I was interested in seeing how it evolved over time, and then how we can continue to have a conversation around pediatric ethics to provide the best care possible. So the conversation around pediatric ethics first became publicized in 1995 after the case of Billy Best. So Billy was 16 years old when he was diagnosed with Hodgkin's lymphoma, which is a common but highly curable form of cancer. However, after 2 months of treatment, he ran away from home because he felt like the treatment was doing more harm than good, and he would have preferred to have alternative treatment instead. This led to a media outcry both in support of Billy and his parents, but overall it led to the question of how much autonomy and decision-making power should kids have in their medical decisions. And it really highlights the tension between both the physicians and parents wanting to have the best interests of the patient in mind, but also the autonomy that young patients should be afforded and the consideration that they should have in their own treatment. So the American Academy of Pediatrics establishes the guidelines for all things pediatrics, from vaccines to clinical trials, but they have important information on guidelines for decision making. And before the case of Billy Best, so in 1976, the involvement of kids in decision making was very limited. It was mostly focused on how parents are in charge of their children, and so therefore they get to make the decision. However, in 1995, which was a year after the Billy Best case, there was an update that enhanced the autonomy of patients. And then in 2022, there was a symposium that was focused on expanding pediatric care, pediatric autonomy and decision making, and it focused on involving kids in the decisions, and also emphasized that parents have a lot but not unlimited power in decision making, and it also gave physicians the responsibility that when they feel like the parents aren't making decisions in the best interest of the kids, they're able to step in and help. And research shows that when kids are given more autonomy, it has better outcomes. So when kids feel like they're being heard, they're more trusting of healthcare providers and more compliant with treatment. So even being able to decide what arm to get the IV in will allow them to be more comfortable in an already uncomfortable situation. And so expanding the autonomy is important for helping patient care. However, guidelines are not going to be applicable to every situation, and there's always going to be challenges that arise. So I wanted to look at some common instances where the guidelines might not be inclusive of all of the complications that can come up. So the first one is determining competency. So in any healthcare instance, there has to be a certain level of competency for patients to be able to consent to procedures. But this is complicated in kids because there's not a certain age where you can say whether or not a kid is competent as kids mature at different rates. So there's something known as the Gillett Competency Test, which is used by physicians to assess whether or not kids can consent to treatment. So they have to assess whether or not kids can explain their choices and explain their treatment in order to determine whether or not they can agree to it. And then the second one is handling disagreements. So as we saw in the Billy Best case, when there's a disagreement, defaulting to parental decision doesn't always equal the best treatment. So it's really important that you are not only getting parental consent, but something called pediatric assent. So assent is more of an affirmative agreement where the three parties, so the physicians, the parents, and the kids, can come together and come to a better decision that will include the patient's wishes, so overall leading to better outcomes in healthcare. The third one is cultural differences. So again, this is going to arise in many healthcare instances, but in pediatrics specifically, there's disclosure of prognosis is not always agreed upon across different cultures. So in the US, it's most common to disclose prognosis to the kids, but that's not the norm everywhere. But in this case, it's important to practice cultural relativism, or the idea that not one culture is superior to the other. So in doing this, you're respecting someone else's culture, which in doing so is going to promote their health and well-being. And so it's just coming from a place of understanding and making sure that you're not being disrespectful of other cultures. So in that case, following cultural relativism. And then the fourth one is confidentiality. So it's kind of the opposite of it's kind of the opposite of non-disclosure of prognosis, but there are going to be instances where kids are going to want to keep things from their parents. And in the state of California, any healthcare related to mental health or reproductive health of kids can be kept confidential from their parents, and it's trying to help them and like empower them in their healthcare. And so in that case, it's important to follow the California guidelines and keep that confidential. But if there are instances where a physician believes that the patient is going to be in harm's way if they don't let the parent know, then it's their obligation to tell the parents of that happening. So overall, there has been a great increase in autonomy, and that will lead to furthering the well-being of young patients. But I think it's important to continue having the conversations, just as in the Billy Best case sparked change. It's important to keep talking about it so we can protect our youngest patients. Thank you.
Thank you so much, Sarah. That very provocative talk. Question for Sarah, please.
Yes, Maria.
What made you want to look into this?
Yeah, so I was a camp counselor for years, and I think kids are really smart and they know a lot more than people give them credit. And so I think, also like on personal experience, I was like the kid like in the doctor's office they'd like hold down to give shots to, and I think if maybe I had like been given a little bit more choice in that, I would be more comfortable and like not have like the fear of shots that I have now. So yeah, I just think like it's really important to listen to kids and like respect their autonomy because they know a lot. And I think especially with healthcare where it's so personal and can be so like detrimental to their health, yeah, it's important to consider all of that. Yeah.
Great. Well, thank you so much. All right. Thank you so much. And also, our next speaker is Maria Sakarets, a junior public health and neuroscience major, double major, and her topic will be racism in kidney care, exposing disparities and seeking solutions. Maria, over to you.
Thank you, everybody. First things first, I would like to get a definition out of the way. Quick show of hands. How many of you know what dialysis is? Okay, so a couple people don't know. I'll spell it out. Dialysis is a treatment that's used to supplement kidney function in patients that have chronic kidney disease, or CKD. It is a very intensive treatment that is very exhaustive and very complicated. It's a huge commitment and ends up being a part-time job for most patients. It involves having a patient come in every other day into the dialysis clinic for 3 to 4 hours at a time in order to be dialyzed. Dialysis is a very intense treatment, and having worked as a dialysis tech for a little under 2 years really inspired me to look into the problem of racism in kidney care. So why kidneys specifically? Kidneys are actually the organ that is in most demand in the United States. At this very second, I can promise you that there are at least 90,000 people waiting for a kidney, and every single day, 11 people die waiting. And these stats are only based on individuals that are eligible for a kidney transplant. Several more aren't eligible to be on the kidney transplant list. So keep in mind that these stats are probably a lot more inflated than we think. The way that race plays into this story is unfortunately through disparity. The need for kidneys in this country is very, very intense. Despite making up only 13% of our population, 35, more than a third, of all patients receiving dialysis for CKD are African American. Black people are consistently shorted at every step of the CKD care process, from start to finish. And a lot of this has to deal with issues of structural racism. This all begins in Black people having a higher propensity for developing diabetes and hypertension, again, due to structural inequalities. Diabetes and hypertension are the biggest heavy hitter comorbidities for developing CKD. CKD is the end of the road for both of these very difficult conditions. Black patients, when they are receiving dialysis, they are consistently shown to receive less quality dialysis than their white counterparts. They're also most prone to premature AV graft failure. I've inserted a picture for the 2 ways that we can do dialysis right above. The leftmost one is an AV graft. It's a surgical connection of an artery and a vein that creates for a very high pressure access that allows dialysis to happen. In other words, because this thing is so inflated and allows such high pressure on the inside, we're able to pull out giant volumes of blood from a person and then pump them back into the individual once the blood is cleaned and extra fluid is removed. The other way that dialysis can be performed is through a CVC. It's called a central venous catheter, and that's the image you see right there of the person with the lumens in his chest. CVCs go straight into the heart and therefore have a very high rate of infection. Black patients unfortunately have the highest rate of contracting staph infections with CVCs. So again, Black patients are consistently shorted when it comes to receiving dialysis and receiving kidney transplants. Black patients are 4 times less likely to receive a live donor kidney than a white patient is, despite having the same exact EGFR calculation rates. And yep. This, of course, is all connected to structural and systemic racism. Social determinants of health play a huge role in this matter, and most of them are outlined in this beautiful graph. What it all ties down to is essentially a lack of resources, education, and health literacy in the Black community. There is also a very valid mistrust of healthcare workers in the Black community. And all of that is escalated and turns into having these awful outcomes for a marginalized community. As I mentioned earlier, hypertension and diabetes are the biggest comorbidities of this horrible, horrible disease. And Black patients are 20% more likely to have been diagnosed with hypertension and 1.4 times more likely to be diagnosed with diabetes. Another thing that we can concretely tie back to being a vehicle of structural racism in kidney care is the EGFR calculation. This was a calculation created in the 90s, and it included a racial factor that essentially labeled the kidneys of Black patients as being more healthy than those of white patients. So for years, up until 2021, this racial factor was used to short Black patients of their time and health. Hundreds of thousands of Black people missed out on kidneys because of the racial factor used in this calculation. Obviously, this violates a plethora of ethical challenges. Justice and autonomy are the ones that come to the forefront. And of course, in my opinion, this is an egregious violation of human rights. The color of somebody's skin should in no means define the quality of their care. And unfortunately, this doesn't only deal with individual results. This has huge implications for community results in the Black community. Obviously, these misfortunes have huge implications for them because it reinforces things like implicit bias and erodes the trust in healthcare, which is already really weak between the Black community and healthcare system. Yeah, so what possible solutions look like for this issue are addressing social determinants of health. The more we work to educate and give resources back to this marginalized community, the more we might be able to mend and bridge that gap between trust and care. There is also a huge need for the reform of transplantation policy. The fact that the racial factor for the EGFR was able to go on unquestioned for about 20 to 30 years is a huge factor. A huge factor of this. Also, as our country moves to a culture that prioritizes individualism and doesn't prioritize diversity, it is more important now than ever to diversify the nephrology workforce to ensure that we're delivering culturally competent care to the people that we are putting at risk the most. And that's all I got. Thank you so much.
Thank you so much, Maria.
Any questions?
Please.
Yeah.
I don't remember how much it passed by or if it passed, but a couple years ago on the California ballot there was a bill for including whether or not how much you drink in deciding whether or not you get a liver transplant or a kidney transplant. Is that anything about that?
I don't know anything about that. That kind of goes into the larger issue of noncompliance. Black and other patients of color are so much more likely to be labeled as noncompliant in terms of their course of treatment. That includes things like drinking, substance use, missing dialysis treatment, and all of that combined results in Black people being far less likely to be eligible to even be on the transplant list. That's an interesting thought, though. I don't know any specifics, but noncompliance is also an issue that systemic racism has touched when it comes to CKD.
Marie, could I just, so if you're non-compliant in these various ways, that means you may get downgraded or bumped off the list to be next in line possibly for a kidney.
100%.
Okay, thank you so much. All right, thank you so much, Maria. All right, our next presenter will be Hermon Weldy, who is a junior public health major and biology major and a medical and health humanities minor. And Hermon will be speaking on Race is Not Biology, the Dangerous Legacy of Race-Based Medicine. Hermon.
Hi, everyone. Today I will be talking about race-based medicine. Race-based medicine is built on exploitation and exclusion. Unethical practices have driven clinical settings to have race be a variable in clinical settings. The Human Genome Project, which was completed in 2003, confirmed that all humans are 99.9% genetically identical. Yet, despite this scientific evidence, race continues to be a biological variable in clinical settings. For example, Black patients often do not receive adequate treatment for pain due to beliefs that they have higher pain tolerance. We see this play out in these headlines. These are headlines from different sources where we see these dangerous beliefs being perpetuated, and these beliefs stemmed from slavery-era pseudoscience. Medical exploitation of Black bodies dates back to this era of slavery. Doctors use Black bodies to perform harmful, and countless of experiments. And like Sydney had mentioned earlier, figures like Dr. J. Marion Sims, who is known as the father of modern gynecology, used Black women to perform experiments and oftentimes did not use anesthesia on these women due to these beliefs that they do not feel pain the way that other people feel pain. Another example, and a more well-known example, is the Tuskegee syphilis study. The study lasted 40 years, from 1932 to 1972, and this study looked at the natural progression of untreated syphilis in 600 Black men. These men were misled and were not given treatment despite penicillin having already been established as the standard cure for syphilis in 1947. Despite these harmful experiments and exploitation, we can see how this has led to Black bodies being seen as biologically different, despite there being no scientific evidence for that. This leads us to the ethical principles that are violated through this medical exploitation and experimentation. The first is informed consent. Informed consent is when permission is granted by the patient to their doctor for medical intervention, and they are supposed to be fully knowledgeable of all the risks and benefits. And so we can see in the Tuskegee syphilis study that the participants had no idea what the risks and benefits of the study were, yet they were still subject to that experimentation. That also leads us to the next principle, autonomy, which is the ability to make your own decisions and exercise your free will. And when their right to informed consent is violated, that also violates their autonomy, as they're not able to exercise their free will. And like those Black women who were subject to those experiments, they had no choice. So their autonomy is also being violated. It also touches upon a topic called therapeutic misconception, which is when participants mistakenly believe that decisions regarding their medical care are for their benefit. So in the Tuskegee syphilis study, these participants believed that they were going to receive treatment and that these researchers had their best intentions, when in reality, the scientists had no intention of giving them treatment and were only focused on collecting research and advancing scientific knowledge. Modern manifestations of race-based medicine include what Maria just talked about, the EGFR calculation. And so this is a calculation for kidney function. And so there is an adjustment to that calculation that includes race. And it is based on the fact that Black patients having higher muscle mass, which is affecting their creatine levels. And so therefore, this adjustment leads them to believing that they have stronger kidney function, when in reality that may not always be the case. And therefore, this is leading to misdiagnosis and delayed treatment for various kidney-related illnesses. Another example, like Sydney had talked about earlier, is the fact that Black women are 3 to 4 times the more likely to experience pregnancy-related complications compared to their white counterparts. Oftentimes, their cries for pain and other concerns are ignored because of things like this idea that they have higher pain tolerance and purely because of racial biases and ignorance. In order to increase inclusion and rebuild trust, there needs to be more diverse representation in clinical trials. This allows for marginalized communities to feel more comfortable and to know that the research and medicine that is being conducted is for them, not against them. By focusing on truth, equity, and inclusion, it allows for a change in perspective and ensures that research remains ethical and valid. And by shifting our perspective away from race, it allows us to ensure that the dangerous beliefs and practices of the past remain in the past. Thank you.
Thank you so much, Ramon, for that wonderful presentation. Question, please.
Great presentation, and I really appreciate you bringing light to this topic. I was wondering if throughout your research, we talked a lot about the Black population and the disparities that they faced. Did you find any other populations that were severely affected as well throughout your research?
Yeah, I mean, for the most part, I did focus on African American populations, but I know that historically, like, Latino women have been subject to a lot of dangerous practices in healthcare. They had to undergo things like forced hysterectomies and other forced sterilizations. So race has manifested in healthcare in like many different ways. So yeah, African Americans are not the only population affected that, but I did focus mostly on that.
Thank you.
All right, I'm sorry, we have another question, please. Yes.
I was wondering if you knew anything about kind of like how class plays out. So like within the different like racial, like within like the Black population, for example, like are people who have like more money and like better access to like healthcare, do you think that they also have the same like level of like, I guess, racism in healthcare?
Yes, I believe they do, just because I think a lot of times, like, it doesn't really matter whether they're educated or whether they have money. I think it's because of these dangerous beliefs that their bodies are different biologically, which is not true. So I feel like it doesn't really matter whether, like, because a presentation earlier talked about how, like, I think some of the poorest white women still have better outcomes than the richest Black women. So class really doesn't really make a difference. I think because these beliefs are so ingrained, it really doesn't make a difference.
All right, please give it up for Ramon. Thank you so much. All right, our next presenter will be Elsa Kinney. And Elsa is a senior biology and public health major, and she will be speaking on the topic, Inequities in Organ Transplant Allocation, Exploring Disparities in United Network for Organ Sharing Scoring Systems. Elsa, over to you, please.
So there are currently over 100,000 people on the organ transplant waiting list in the United States alone. And looking at like the makeup of this list, 60% of people on the list are from minority communities. And when looking at the wait list, I want to highlight, and like Maria did talk about this in her presentation as well, I want to highlight that there are a lot of people who do qualify for it, but because it's so full, they have to wait months or even years to get on the wait list. And so from these waitlist inequities alone, it's very clear that there are a lot of disparities and inequities in the organ transplant system in the United States. And these disparities are often driven by implicit bias in referrals and eligibility evaluation for who gets on the waitlist, and this ultimately determines who receives an organ transplant. So UNOS is the United Network for Organ Sharing. It was founded in 1986, and it oversees all donations and transplants in the United States. It is a very centralized system, so it does raise a lot of ethical concerns because it is a very big single entity that is in control of such a crucial part of healthcare. It's in charge of reforming, developing, and creating new policies and scoring systems for various different vital organs. And this is very important because there's such a huge organ shortage in the United States right now. About 90% of the US population supports organ donations, but only 60% are actually registered donors. So there's a huge gap there. And considering that, as well as the fact that UNOS is such a centralized system, it's so important for them to make policies that are very just and fair to ensure that they include diverse biological factors and to eliminate any biases. So for kidney transplant scoring, they use two main scoring systems. The first is the Estimated Post-Transplant Survival, or EPTS score, and the second is the Kidney Donor Profile Index, or KDPI score. The ETPS score looks directly at the patient who's in need of a kidney, and they evaluate what their prognosis will look like after they receive a transplant. It's scored on a scale from 0 to 100, and a score of 0 to 20 is ideal, and it indicates that you will have a very great prognosis. The Kidney Donor Profile Index looks at the donated kidney, and it's a very similar scale. It's scored on 0 to 100, with a score of 0 to 20 being the most favorable, and that means that it is very good quality. So typically, patients who have an EPTS score between 0 and 20 get a better kidney that has a better KDPI score, so also between 0 and 20. And these systems have been around for a very long time, so there's been a lot of research on both of them. And they found consistently that in the EPTS score, there are a lot of racial biases. Specifically, there was a study done in 2019, and they looked at the waitlist that year and also the number of people that received transplants that year. And for white and black candidates on the list, it was a pretty similar racial makeup that year. About 38% of people on the list were black, and 31% of people on the list were white. But when they looked at the actual transplants given out that year, it was so different. 65 of the preemptive transplants went to white individuals, and only 17 went to black individuals. So this is largely due to a lot of structural racism and a lot of systemic inequities. Like Maria touched on in her presentation, Black people are more likely to develop diabetes, and then they're more likely to be on dialysis for much longer than their white counterparts before even getting on the transplant waiting list. And the dialysis time factor is such a huge it's such a huge factor that's heavily weighted in calculating your EPTS score. So this is obviously putting them at a disadvantage right from the start. And considering this, it is important for these scores, or other scores, to consider socioeconomic factors. This would greatly increase the number of kidneys allocated to Black and other racial minority groups. And I also want to highlight that it would favor lower income groups as well. There have been a lot of studies also showing that lower income groups receive 2 times less the amount of kidneys than those from the highest income brackets. So for liver allocation scores, they use an entirely different scale. They use the Model for End-Stage Liver Disease, also known as MELD. It takes into account various different factors from age to how long you've been on different treatments and if you've received other transplants as well. But it uses a different scale. It's not from 0 to 100. It goes from 6 to 40. And if you have a score that's closer to 40, that means you're in more urgent need of a liver and you're going to be more prioritized on the list. It also looks at various chemical factors that indicate poor or good liver function. The 2 big ones are bilirubin and creatinine. Sorry, it says creatine on the slides, but it should be creatinine. And this system has also existed for a very long time. We're on MELD 3.0, so there's been various different versions beforehand. And the studies, once again, there shows a lot of consistency in gender bias in these liver allocation scores. There was one study that found that women on the wait list were 10 times more likely to die and receive 15% less livers than men do. And this is because MELD uses the same calculation for both men and women, and this is very inaccurate for creatinine calculations for women, because women typically have less muscle mass and therefore less creatinine in their bodies. So even though a man and woman might have the same poor functioning liver, the man is always going to have a better score than the woman. And MELD did account for this. They created a new version in 2023 called MELD 3.0, and they added 1.3 points for every woman. But this was still not enough because it didn't fully account for the range of creatinine scores that women have. So the numbers, the population statistics haven't really changed that much since then. And other countries have also used the MELD system. It's not just the United States, but some have also recognized these inequities and they've transitioned to newer models. Two in particular, the UK and I believe Australia. They decided to take the GEMMA sodium model instead, and this uses more gender-neutral indicators. They still factor in bilirubin and creatinine, but they don't weigh it as heavily, and instead they focus on sodium. And this has been very promising and has shown really great statistics. So, ending my presentation, I just want to encourage you all to take action. UNOS reviews its policies twice a year, once during winter and once during summer, and it's completely open for public comment. They usually have about 10 policies up in this past cycle. They had a few policies relating to more equitable kidney and liver allocation scores. So there are a lot of reforms that are trying to create a more equitable system. And I would highly recommend reviewing the policies. They're going to be posted soon, and they're going to be open for comment in July. And hopefully through collective action, we can create a more equitable system that allows a fair chance for everybody to receive a life-saving organ. Thank you.
Thank you so much, Elsa. Question for Elsa. Yes, please.
I don't know if you have any info on this, but do you know how geographic location might affect somebody getting access to an organ?
Yeah, so I think UNOS supposedly has a fair system for allocating organs across the nation, but when it actually comes down to when they're flying it across, sometimes they're making just rash decisions and they're kind of just choosing based off of who's closest when that's not necessarily the system that they have in place. One of the reasons why I decided to pursue this topic is because I'm from Hawaii and they are obviously very far from the continental United States. And there's a recent news article that showed for every 40 kidneys that Hawaii sends out, they only get 1, 2, 3 back, which is pretty insane. So they do technically have policies in place, but hospitals don't always follow them.
Thank you so much, Elsa. Let's give it up for Elsa here, please. A senior biology major and philosophy minor. And Jesse is going to speak on the topic, the destruction of safe spaces. How the new ICE policy undermines healthcare access for undocumented immigrants. Jesse, over to you, please.
All right, hello. As he said, my name is Jesse Vargas, and today I'll be talking about healthcare access for undocumented immigrants. More specifically, I want to talk about a new policy that allows for ICE agents to enter hospitals, which undermines the kind of safety and care that these places are meant to provide. So to begin, I want to start by sharing a story of Ulises Peña Lopez, who is a 30-year-old undocumented immigrant. And on February 21st, he was just sitting in his car, parked in Sunnyvale, the place that I've always called home, when he was approached by ICE agents. At this point, he tried to invoke his right to remain silent and also requested that a lawyer be present. However, instead, the ICE agents shattered his car window, they dragged him out of his vehicle, and then they began to assault him. Unfortunately, Ulises already suffered from multiple pre-existing health conditions, including multiple blood clots, a heart condition, a spinal disorder, and also multiple knee injuries. So, safe to say, this assault ended up causing him to collapse, and he was rushed to the hospital. However, instead of receiving the type of care that one would expect to receive from a hospital, he was instead served as a facility for further harm to be done. So when he arrived at the hospital, he was chained up to his hospital bed, and the ICE agents prevented the hospital from giving him any food, water, or even medications that could have helped his condition. He was also prevented from speaking to his attorney while he was at the hospital. And then, in the middle of the night, before he was even given a chance to recover, he was transferred to a detention center, and his family was not made aware of this either. And this is where he still remains today. So this is just one tragic case of the kind of way that this policy has an impact on people. So what exactly changed? Well, previously, ICE agents operated under guidelines that were meant to keep sensitive or protected areas like schools, hospitals, and places of worship free from any sort of enforcement actions. And this was made very clearly, this was clearly expressed in a memorandum issued in October of 2021 by the former Secretary of the Department of Homeland Security, Alejandro N. Mayorkas, who stated that they could complete their enforcement missions without denying access to needed medical care. The issue was very simple for him. He didn't think that people should have to fear deportation when they are trying to seek help. However, recently in January of this year, the acting Secretary of the Department of Homeland Security, Benjamin C. Huffman, issued a new memorandum. And in this memo, it created a new policy that allowed for ICE agents to use their own discretion or common sense, as he puts it, to decide when they should be enforcing immigration laws within these safe spaces. Unfortunately, this type of ambiguity and uncertainty makes it very difficult for undocumented individuals to decide whether or not they want to seek care. So, from a bioethical perspective, this new policy change is pretty problematic. For today, I'll just be talking about two principles: justice and non-maleficence. So, if we look at justice through a distributive lens, it's all about making sure that people have fair access to resources like healthcare. However, this policy change discourages undocumented immigrants from trying to seek help out of fear that they might be detained or even deported if they go to a hospital. Additionally, this isn't just unjust, but it can also be very harmful and damaging. When we consider the principle of non-maleficence, or the commitment to avoid any sort of unnecessary harm whenever possible, this principle is also being compromised. When we think about people avoiding medical care, it can have a lot of downstream negative effects, such as the development of chronic conditions that could have been prevented, or it can also cause people to spread contagious diseases that they didn't even know about because they weren't treated. Additionally, undocumented immigrants also already suffer from a lot of barriers that prevent them from seeking healthcare, and some of those include financial barriers like insurance, and today I'm mainly talking about the fear of deportation, which isn't necessarily a new topic either, considering that a study was conducted in 2017 and 2018 during the current president's first administration term, where they discovered that 24% of undocumented Latino immigrants avoided seeking medical emergency treatment out of fear that they might be discovered as undocumented. And I fear that with policy changes like this, it's only going to get worse. So what exactly can be done about it? Well, healthcare institutions like Santa Clara Valley Medical Center have already released public announcements where they state that they will not be asking their patients about their immigration status, and that they will not be cooperating with ICE in ways that jeopardize their patients' care or their right to privacy. Additionally, they provided links to a network called the Rapid Response Network, which is just supposed to be a resource for patients to understand their rights during these types of scenarios. And lastly, I think that it would also be really important for healthcare institutions to begin to train their staff on how to basically understand their patients' rights in these scenarios, or even also the types of laws that could be applicable. And I think most importantly, how to interact with ICE agents in the event that they do choose to enter these spaces. Ultimately, I think that it's stories like Ulises's that tell us that policies really do have a real and sometimes devastating consequences on people's lives. You know, hospitals are meant to be places of hospitals are meant to be places of, safety and sanctuary and care. And yet recently they are turning more into places of fear. And I think that it's not only ethical, but it's necessary that we make sure that we expand our healthcare access to everybody regardless of their immigration status. And lastly, I just want to end by stating that I think it's also very important that we begin to advocate for policies that ensure that our hospitals remain places of care rather than places of fear. Thank you.
Thank you so much, Jesse. A very topical subject. And a question for Jesse, please. Yes, please.
Yeah, so you talked about earlier how Santa Clara County is kind of fighting back against like the ICE policies and like making sure that their patients are protected. Like, what is the role between like county and like federal programs, and like how does that like reciprocation, could that lead to more like damage? Like, is there like certain like laws that prevent them from fighting back against like federal laws, or how does that work?
I haven't really looked into that much. However, I think in general, sorry, I didn't have time to think about it. But I would say that there are certain precedents that have already been set that allow for hospitals to be taking this action. Like if we consider EMTALA, or the Emergency Medical Treatment and Labor Act, it already requires that all Medicare-funded hospitals provide some base level of treatment to patients in order to, stabilize them. And so in a way, I feel like there is already this precedent set for these people to be treated. But yeah, I haven't really looked about like how that would be affected.
Yes, please.
Yeah, I just wanted to expand on the EMTALA point. HIPAA is also a thing that hospitals are trying to fight back against ICE with, because it's a matter of patient privacy that ICE is trying to impose on, and then EMTALA, like you mentioned, like the Patient Abandonment Act. That's also something that hospitals are trying to use to justify pushing ICE out of places that people are seeking healthcare.
Yeah, thank you. That's also a great point.
Well, let's give it up for Jesse. Thank you so much, Jesse. Great. Our next presenter is Megan Abati. And Megan is a senior neuroscience major and economics minor, and she will be speaking on the topic, Opening the Black Box, How Artificial Intelligence Increases Race-Based Disparities in Medicine. Megan.
Thank you. Yeah, so I'm going to be talking about race-based disparities as a result of artificial intelligence. And when I say artificial intelligence, really what I'm talking about are these clinical support algorithms. And what those are essentially just online tools that physicians can use to help them make decisions about how to move forward with patient care, or help them make diagnoses. So maybe a radiologist would use AI to help them analyze an X-ray, or maybe an obstetrics physician would use an online algorithm to help them decide if their patient is at risk for developing certain health complications if they undergo a C-section, something like that. So this image is just showing you that there are lots of ways that AI can be implemented in the healthcare space. The issue, though, with some of these algorithms is that they might not work as well for people of color. So some of these algorithms are based on training data that show racial biases, and these algorithms therefore output racial biases. And I want to show a few examples of that. So our first example is from a study in 2019 published in a journal called Science. And essentially this study is analyzing an algorithm that is supposed to help physicians decide if their patients are eligible for a program called high-risk care management programs. And these are essentially just programs of care for people who have complex illness or multiple chronic illnesses. So how do these algorithms work? First, the physician will input the patient information, so probably their vitals. They would input for sure their chronic illnesses, all of their other diagnoses, how many chronic illnesses they have, and also healthcare costs. Notably, though, the physician discludes race, so the algorithm has no idea what the race of the patient is. But the problem comes in when the algorithm learns to associate healthcare costs with healthcare needs. So, and this is on purpose. The algorithm is trained to do this. So what it's doing is it's saying, okay, we have a patient who's spending X amount of dollars on healthcare, or rather their healthcare program is spending X amount of dollars on their treatment. And that means that this patient needs X amount of medical attention. And the issue, though, is that we know in America there are systemic barriers that prevent certain racial groups from accessing healthcare or healthcare of high quality relative to white people. And that's what this graph here on the right is showing. So we see mean total medical expenditure as a function of chronic illnesses. And Black patients who are depicted by the purple line are showing that they're spending less money on healthcare, or again, their healthcare is spending less money on their treatments, relative to white patients who are depicted by the orange line. Of course, this isn't a perfect comparison. It doesn't encapsulate all races, but I think it's still a fairly powerful example. And this is linked to my blog, this study showing this graph. And so when the algorithm learns that, okay, we have Black patients who are spending less money on healthcare, it turns out that it's systematically underrepresenting Black patients by underestimating their illness. So the algorithm would say, we have a patient who's spending less on healthcare, therefore this patient isn't as sick as somebody who's spending more on healthcare, when really they could be just as sick, if not more sick, as the white patient who happens to be spending more on healthcare. So this is just one example of an algorithm systematically underestimating Black patients' illnesses and thereby potentially recommending physicians to undertreat these patients. The second case I want to show is regarding malignant skin condition detection apps. And in this case, the user is actually just the patient. So if I have, let's say like I have like a mole on my arm and I want this app to tell me if it's skin cancer, I can upload a photo of this spot on my arm to an app, and the app is going to take that photo and compare it to other data, other images that show similar, malignant skin conditions. And it would also compare it to images that are showing benign skin conditions. And hopefully it would tell me, is this a benign spot or is this something that's cause for concern? The issue with these algorithms is that a lot of them are trained on data sets that are over-representing what malignant skin conditions look like on white patients relative to what those skin conditions look like on patients with darker skin. And that's what this pie chart on the right is showing. So we can see that the majority, 98.7% of the images in this data set are for lighter skin. And there's some smaller percentage of images that are for darker skin tones. And so this is the kind of data that these apps are using. This study was actually done on Google Images. A lot of these apps are not trained on Google Images, but they are trained on data sets that do show a similar breakdown. And that's been shown in that article, is linked to my blog as well. And so you can imagine that when these apps are trained on these data, they're not going to work as well for people who have darker skin. And a lot of times users don't actually even know this because the developers aren't disclosing this information. And that can be certainly harmful for either under or overestimation of malignant skin conditions. Okay, so hopefully what I've just convinced you of is that even without explicitly including the race of the patient, so in the first example, you don't actually have to input the race of the patient. In the second example, it's a little more convoluted, but you don't have to come out and say the race or ethnicity of the patient. The algorithm will still find a way to bake systemic bias into its outputs because it's often they're being trained on data that show racial bias. And this is related to something called the black box problem, whereby the algorithm functions as a black box. A lot of times we don't know what calculations or biases the algorithm has until often it's too late, so to speak. And so the algorithm calculates some kind of output that we're just supposed to trust. And I argue that developers should increase the transparency of what's inside the black box, what kinds of data they're using to train their algorithms, and what kinds of calculations are involved in that. And also, clearly, there needs to be more rigorous testing before these algorithms are released because it'd be good to know beforehand what kinds of biases are at play here. So hopefully we can prevent those or make people aware of them. That's all. So thank you.
Thank you so much, Megan. And also getting us into AI and all. Yes, please, a question.
Yeah, are you familiar with how this applies to AI scribes at all?
I am not.
Okay.
Sorry.
No worries.
What's up, Elsa? Oh.
Well, for the first algorithm, you remove the healthcare costs that include the bias.
Yeah, that's a good question. So for this algorithm, what this study actually showed, this study in Science that I have on my blog, it showed that if you do remove healthcare costs, if you remove that proxy, then it would eliminate the racial bias from this algorithm. The reason they include healthcare costs in the first place is because ideally, in order to calculate like which patients are best suited for these high-risk care management programs, you would go through and look at the treatment history of each patient. And so that way you can see what treatments are effective and what kinds of needs this person has in terms of healthcare. That would take a lot of time. And at that point, I think this algorithm might not even really be saving much time for the physician. So instead, what the developers must have done is just said, well, let's just use healthcare costs as a proxy for the needs of the patient. And of course, that ended up producing lots of racial biases. So I guess the answer to your question is yes, it would. But I think the developers would need to go back and think about how they would want to address healthcare needs, what kinds of proxies they would use instead.
Well, thank you so much, Megan. Let's give it up for Megan, please. All right, our next speaker is Cassandra Blake, and Cassandra is a senior biology and public health science major, double major, and her topic this evening is menopause is deprioritized, leaving the root cause of women's health concerns overlooked. Cassandra.
Hi, is this on? Okay. I'm Cassie, and today I'm just going to be talking about just how deprioritized menopause is as a women's health issue. So I wanted to kind of start by just getting a show of hands. How many people in the room think that if asked right now, they could define menopause? Okay, a few. Second question, how many people think that if asked right now, they could provide 3 or more symptoms of menopause? Okay, maybe less, maybe about the same. Okay, well, hopefully this talk is informative then. So I wanted to start just by really highlighting how deprioritized menopause is in our society. An article from the American Journal of Managed Care states that 80% of medical residents feel, quote unquote, barely comfortable discussing or treating menopause. And an article from the American Association of Retired Persons states that only 20% of obstetrics and gynecology residency programs actually teach their residents about menopause-related training. This has direct implications on patient-provider discussions about menopause, as we see that 42% of women aged 50 to 59 years old say that they've never discussed menopause with a healthcare provider. So what is menopause anyway? Why is it important? Menopause is defined as the time when someone's menstrual period has stopped for at least 12 consecutive months, and at this point they are no longer able to reproduce. The average age of menopause is 51 years old. And most people, when they think of menopause, they think of the most common symptom of hot flashes, but there are actually over 30 symptoms of menopause that can be really debilitating to people's lives. These are things like joint pain, brain fog, irritability, anxiety, mood swings, etc. So menopause is further deprioritized in terms of funding, especially in the US. In 2013, 9.7% of NIH research grant spending went towards women's health issues. And in this same year, the NIH's total research grant spending was $26.3 billion. Fast forward a decade to 2023, and only 7.9% of NIH research grant spending went towards women's health issues, while the NIH's total research grant spending for this year in totaled $43.7 billion. Just to further this point, in 2024, the NIH spent only $56 million on menopause as a category of women's health issues. And this leads us to a lot of ethical challenges. I will start by kind of providing an example about the first 4 on this list: fully informed consent, autonomy, misdiagnosis, and inadequate treatment. So picture a 51-year-old woman who goes to the doctor complaining of joint pain. Her doctor has not had a formal education about menopause and thus is potentially not comfortable discussing or treating menopause, or maybe just doesn't know how to recognize the signs and symptoms of menopause. Neither the patient nor the provider know that joint pain is actually a very common symptom of menopause. So this woman is diagnosed with arthritis by her healthcare provider, and the healthcare provider prescribes her with arthritis medication, which she consents to begin taking. The issue here is that this woman is actually in menopause and could have been prescribed something that would more effectively target her menopause itself as opposed to just the symptoms, such as hormone replacement therapy. So she is lacking fully informed consent because she wasn't made aware of all of the treatment options that could have helped her. She is experiencing diminished autonomy due to this. She was misdiagnosed with having arthritis when really the cause of her joint pain was her menopause, and thus she also has inadequate treatment or just not the most effective treatment that she could have possibly been offered. There are also justice issues with the deprioritization of menopause. The one that comes to mind the most is if doctors have different levels of knowledge about menopause, women will receive different amounts of care and different information about menopause depending on which doctor they see. And I mean, I'm sure we can all say that we have chosen a doctor at some point in our lives based on which doctor is going to take our health insurance that we have. So the issue that is concerning here is that maybe people with lower socioeconomic status who might not have as much health insurance coverage would end up going to doctors that aren't able to help them as much as somebody of higher socioeconomic status. There are also access to care issues with the deprioritization of menopause. Specifically with educational attainment level, we see that women of higher educational attainment level actually have decreased severity of menopausal vasomotor symptoms compared to women of lower educational attainment levels. And vasomotor symptoms with menopause are just things like night sweats and hot flashes. And then in terms of socioeconomic status, we see that people of lower socioeconomic status actually have less education about menopause. And studies have shown that gynecologists feel that the majority of their patients that come to them asking for information about menopause or menopause-related care are actually white and well-educated. And this disparity is further exacerbated in private clinics as opposed to public. And so I just wanted to offer some possible solutions. I think that a combination of funding for research, more formal education for both patients and providers, as well as just raising awareness to the general public to make menopause less of a taboo topic are needed in order to make sure that patients are making the most informed decisions that they can for their care and also receiving the most effective treatments possible. Thank you.
Thank you so much, Cassie. All right. Question for Cassie, please. Yes.
Is there any internal factors like the gender distribution of physicians that play a role in this issue?
Oh, yeah, that's a good question. I'm not sure about that. I'm not sure, but that would be good to know more about. Yes.
Maybe one other question here.
I was wondering, would you be able to elaborate on the link between education attainment and the vasomotor symptoms you mentioned? What's the correlation there?
Yeah, there was a study, the link is in my blog project online, but it basically just showed that if you have higher educational attainment level, then you're more likely to have decreased severity of those menopausal vasomotor symptoms. So decreased severity in terms of night sweats and hot flashes mostly. And so the concern there is that if we're more educated, maybe we have more access to care, or maybe we're advocating for ourselves more because we know about that. So for people who don't know about menopause, there's a bit of a disparity.
All right. Thank you so much, Cassie. Let's give it up for Cassie here. All right. Our next presenter is Harpreet Basin, And Harpreet is a senior biology major and biotechnology and public health minor. And his topic is the future of skin, vascular, and nerve transplants for financial compensation. Harpreet, over to you.
Thank you so much, and good to see you all tonight. My name is Harpreet Bhasin, and obviously I'll be talking about the future of skin, vascular, and nerve transplantations for financial compensation. Organ transplantation, one of the biggest medical treatments given today, but has so many problems ethically and obviously on a resource level. So usually when you think about organ transplantations, you think about lungs, kidneys, hearts, but let's think smaller. Skin, nerves, and blood vessels. Obviously they're very important for life. Skin transplants can be used to replace damaged skin from burns, toxins, or other diseases. Nerves can be used to alleviate pain from degenerative diseases and fix neural pathways for function. And blood vessels can be used to repair blood vessels from any injuries taken. However, while people may think this is small, 44% of people needing one of these transplantations dies before they're able to receive it due to the lack of donors that exist. And overall, there's current dangers for organ donations because they might result towards illegal markets, which have tremendous dangers for both the patient and the donor. Therefore, we must create a new system for financial compensation in order to increase the donor shortages and provide the most relief to patients. So mostly, thinking back to the history of organ donation, it was mostly unregulated until 1984 when the Organ Transplantation Act strengthened the regulations on organ transplantation. However, it's generalized for all transplantation. However, these transplants are different and they should require an exception for the law. I think, first of all, we're going to talk about simple economics, supply and demand. If there's a supply, there's also demand. Obviously, you have heart and lungs. You only have 1 and 2 in the human body. Therefore, the supply is low, and then demand will be very high. This leads to exploitation that exists currently. But since there's a lot more grafts of skin and nerves and blood vessels, the supply, if we were to open it up, the supply is essentially higher, then the demand will be lower, which will prevent the exploitation that could occur. Secondly, there's it could be all these parts can be extracted from live donors, and their storage methods are a lot different than other organs. They can be stored for longer, and patients can be considered donors even after the time of death. Next, we also have the fact that all these parts have regenerative properties. If you were to remove one nerve from a hand, our body has abilities to recover these pathways, and there's a lower dependence on life compared to other organs like heart and lungs. And overall, right now, we actually provide compensation for other regenerative properties, including hair, bone marrow, leukocyte packs, plasma, and more. So if we are able to provide a form of compensation for these, why not for skin, blood vessels, and nerves? And let's talk about the ethics of this. So from a utilitarian perspective, this is morally permissible because it's going to overall promote the betterment of society and it provides the most welfare for those needing one of these transplantations. Secondly, and probably one of the most important considerations to mention, is altruism. Right now, one of the biggest beliefs on why organ donation for compensation is banned is because of altruism, because people believe that organ donation should be truly altruistic. However, you can engage in something called direct donation, where if someone needs a kidney or a liver, you can donate your kidney or liver to a specific person, aka your family member or your friend. However, you are getting this by providing to this certain individual, you're getting the satisfaction and a secondary form of compensation on the emotional and psychological level that you're giving to a loved one, that your loved one is going to survive compared to a person that randomly needs one of these transplantations. And overall, virtue ethics is also very important. How are we as a society supposed to value the lives of patients needing one of these transplants? And if we were to encourage a system like this, then how are we going to value the life that we're giving to people, or are we going to rely on the monetary funds that overall that we rely on the system for? So I think some future scenarios that we'll talk about is if we don't evolve from the system, we could see obviously a rise in illegal markets. There's tremendous dangers for both the donor and the patient. There's lack of medical oversight. There's very little to no post-operative treatments. And overall, there could be the exploitation of both the donors and patients. We've seen these with certain networks. They'll take majority of the funds and leave the donor with barely any of the money. And what we could do, overall, we need to change from this. What we can do to facilitate this is to create a new system of financial compensation to provide both donors and patients with a form of compensation in order to increase the donor shortage and provide the most welfare for patients. We can do this through a monetary compensation method or a non-monetary compensation method, being through medical benefits, tax exemptions, other resources. I think in order to do this, creating an independent agency is important to provide oversight and support to current transplantation centers in order to maximize efficiency and provide the most safety for the patients and the donors. Transparency and oversight are key to this plan. And overall, evolving upon the current state of organ transplantation is necessary in order to provide the betterment of organ transplantation in the U.S. and advance global health for all humans. Thank you.
Thank you so much, Harpreet.
Thank you.
And all, please, yes, question.
Because if you're offering compensation, it can sometimes lead to exploitation. I guess how do you manage like the pros and cons of that?
Obviously, yeah, I think that was one of the biggest ethical morals that came up in my paper. You obviously there's obviously the chance that exploitation can occur, but I think through the models I suggested, like supply and demand, there's obviously a greater supply on these vessels. There's less a dependence on life. Also, obviously, if you lose one blood vessel or a nerve, you're not going to die. If you lose your liver, then you will pretty much have a very considerable damage to your life plan. So I think overall, there's obviously dangers to this method. But I think in terms of the benefits, it definitely outweighs the negatives. And if there's a strong regulatory support behind this, obviously oversight, you need transparency, you need to give support to all the transplantation centers. That's definitely going to help facilitate the change towards providing this form of compensation and increasing the donor shortage.
Great. Well, let's give it up for Harpreet. Thank you so much. All right. Our next speaker is Krista Gorham. And Krista is going to be speaking. She is a senior public health science major and biology and studio art minor. And her topic is how America's long-winded history of individualism promotes health inequity under the guise of health insurance. Krista, over to you.
Hello, everyone. So today I'm going to be talking about how I feel that a social theory, an American social theory, contributes to health inequity in this country through health insurance. So perhaps you may recall last winter, Luigi Mangione shot and killed the CEO of United Healthcare, Brian Thompson. And whatever your level of familiarity is with ethical principles, do not kill is a very well-known one. So this has been a very complicated case for so many people because millions of Americans have actually been celebrating his death. So I took this picture on the way to San Francisco not that long ago, and I wanted to include it because I've been seeing this everywhere.
So essentially, I also feel that it is unethical to kill, and that's why I'd like to talk about the 45,000 Americans who die every year as a result of not having health insurance in this country. So I first want to address that the United States views healthcare as a privilege rather than a human right. And that I denote to individualism. I have the definition up here, but in essence, individualism is really just promoting individual autonomy and our ability to navigate success through means of self-determination. And that is fantastic. It has allowed us to be one of the most innovative countries in the world, especially when it comes to healthcare technology. However, I have two problems with that. The one being very few people actually really get to be a part of this innovation, and two, not everyone is going to have access to that said innovation at the end of the day. And I feel that this is really reflected well in this graph that I have here. This is just showing our progress compared to other comparable countries. We spend the most on healthcare compared to anybody, yet we have the lowest life expectancy. So health in this country has really been ingrained to be understood as a reward for vast Americans rather than something that they deserve. Speaking of people who are not vast majority of Americans, I picked this quote from an interview following the death of Mangione. Maybe you recognize this guy, but he asks, "Are people really that angry?" And I picked this quote to include because I feel that it really represents this discrepancy that I'm trying to get at here. Yes, people are really angry, and I can tell you why. Around a third of people report being in some level of medical debt, and 40% report having to actually postpone that care as a result of really, really high costs. And as a result, we are home to the highest rates of chronic illness, infant and maternal mortality, suicide, and homicide, probably leading us to having the lowest life expectancy. So this thing that we pour so much money into every single month is not always guaranteed to advocate us when we really need it. And something that I found really interesting in this whole research process is that around 850 million claims are denied every single year. I can only speculate as to why Mangione decided to go after Thompson. However, United Healthcare really topped the charts with claim denials. It was discovered that AI was utilized in going through those claims, and that probably deserves a blog project in itself, but for the sake of time, I'm just going to tell you that I think that is unethical. So somewhere in Luigi's manifesto, he says, "The American public has let them get away with it," them being health corporations, and I have a response to that. I personally feel that the American public has become so exhausted and chronically ill that trying to push back against the system has become increasingly more challenging. And I very fortunately had the opportunity to speak to someone who shared her story in regards to all of this, and she asked to remain anonymous in her story. But in summary, she was diagnosed with a brain tumor, and her insurance through her employer would not cover the cost of the procedure. So in this limbo period of trying to figure out how she was going to cover this cost, mind you, it was an $150,000 procedure. She ended up losing vision in one of her eyes because care was postponed for so long. So finally, she was able to get that procedure, still not sure if it was going to be covered. So following that, she decides to go through an appeal. I then find out that around 1% of Americans actually go through an appeal, and I was curious as to why that number was so low. The person I interviewed, she's highly educated. She is a middle to upper class American who actually has experience in working in insurance for around 11 years, and she described the process of an appeal to be actually impossible. So I'm thinking to myself, how could this be possible for someone without this level of education, for someone who maybe English is not their first language? And from the same survey, I found here, these are some reasons why people didn't go through the process of an appeal. One being that most people don't even know that they have the right to go through with that. a lot of people don't know who to contact, and a lot of people don't have the time. The person who I interviewed, she was trying to raise a family during this time. She was also going through radiation therapy to prevent the tumor from coming back. So how is she supposed to, have the time to go through this process? So talking to her was really profound experience for me because it really goes to show that these experiences are very, very common. And I'm sure that some of you in this room can even relate to a story like this. And I feel that sharing our stories is really important in order to create awareness and kind of begin to place some pressure on these systems that continue to this cycle. I feel that it is actually just such like a significant commonality among so many Americans, and we are the only high-income country that does not have universal health care as a result of our values. So really talking about this, I feel, is the first step towards change. So thank you.
Thank you so much, Krista. I think we can all recognize that in our lives, the powerful topic. And also a question for Krista, please. I'll pose one. So I know, is it Mangione? I think he argued, listen, this healthcare company is killing many people by its denials and all. And how do you balance, like, saying, as you did before, one should not kill, but his claim the healthcare company is killing. How did you evaluate, like, which of those claims do you think had priority and why? Or I should say, how did you prioritize thou shalt not murder over Mangione's claim that, hey, listen, the healthcare companies are killing. This is sort of a justified homicide.
Mm-hmm. Yeah, I think, again, like, you could really go down a rabbit hole and there could be a whole other presentation on why maybe his actions were ethical or not. Obviously, from a moral standpoint, like, we understand that killing is unethical, but maybe if you viewed it from, like, a utilitarian standpoint, maybe that's not the case, just because, like, one versus the millions every single year. And so it's tricky for me because I do, like, condemn his actions, and really since then no change has occurred since his death. But at the same time, there's been, like, a lot of conversation since that, and I think I read, like, yesterday that there's been 1 million donations already to his legal fund, which is quite insane. So there's a ton of support by it, and people really support it. I support, like, the momentum that's created, but I think that is key, is the momentum following an action like that, because we see in our history there is, like, a very strong history of, like, vigilante justice in America, but what matters is the momentum that follows that. But I don't necessarily think his actions were, like, what was needed to start that momentum.
Yes. Thank you very much. All right, let's give it up for Krista. All right. Our next presenter is Karina Martinez. And Karina is a junior biology and neuroscience double major. And her topic is Access is Power, Barriers and Facilitators to Contraceptive Care for Hispanic Adolescents. Karina.
Thank you for that. Hi, everyone. I'm Karina, biology neuroscience major, and my topic for today is going to be about the barriers and facilitators to contraceptive care for Hispanic adolescents. So I want to start off by showing you two quotes. First one is from Carla Cortez. She says that she was raised in a Mexican Catholic household, and talking about sex was a very taboo topic. And something that struck me as I was reading her story was, I learned from TV, which made me sad because it didn't sound real. And while Carla experienced silence, Samantha Soto said that she recalls growing up having those open conversations with her mom. And she says, my mom would tell me, you don't have to wait until marriage, just be sure about who you're with. And a common pattern that she noticed was that a lot of her friends who came from, or who had religious families, they were too shy to talk about sex education with their children, thinking that that might push them towards having sex in the future. And they're the ones who actually ended up having kids at a very early age. So just start off by defining some terms. The World Health Organization defines adolescents from ages 10 to 19. And research has shown that there is a lot of disparity, or significant disparities in contraceptive use, as Hispanic adolescents are less likely to use contraception. 12% reported using contraception in their last intercourse from 2024 data, and compared to white adolescents who reported 24%. And so as a result, this leads to higher teen pregnancy rates among Hispanic adolescents in 25.3 births per 1,000 Hispanic adolescents versus 11.4 births per 1,000 white adolescents. And so something that also contributes to this are the cultural values of familismo, machismo, and marianismo. So familismo relates to having a strong family bond. Machismo is where men are expected to be dominant, and marianismo is where women are expected to be virginal and pure. And so all of these factors contribute towards the attitudes and conversations that go about sex and contraception. And so this data shown here, first I want to highlight at the core of like Hispanic households, familismo is something that is very strong. That it is a cultural value in which strong loyalty, attachment, and obligation to extended and immediate family is highly valued. And as seen here on the right, it's listed as a barrier to contraception. So in general, yes, it does provide that guidance, that support that adolescents need as they develop, but it's also listed as a barrier to contraception because there is fear or shame that asking for a conversation about contraceptive use or talking about sex education will lead to shame or dishonor. As another barrier listed here is the prohibition of sexual activity. And so with this also, Hispanic parents already assume that children are receiving adequate sexual education, but it has been shown that in rural communities especially, that sex education is not comprehensive. It's not highlighting what is needed in order for adolescents to understand their sexual health. And so, for example, in rural communities that primarily serve Hispanic adolescents, it's been shown that the federally funded programs are most commonly abstinence-only programs. And so that's what the students are receiving. They're receiving the messages of just really general health, not really focusing on a comprehensive sexual health education, and also they're only focusing on abstinence only rather than giving education about what contraceptives are available. And so this leads me to a framework that I believe is really important to center this conversation around, which is reproductive justice. And so reproductive justice is the framework in which it values it highlights that everyone has the right to bodily autonomy. So it values that you have the right to have children, to not have children, and parent children in safe environments. And so centering the conversations around this and applying this framework is very important because adolescents are able to understand how they can access contraceptives and just being able to understand what options there are available to them. And also when it comes to primary health providers, it's important for them to also use patient-centered care. And so in this way, they're able to understand the patient's cultural needs and cultural values, and that gives a lot of insight into how to provide that adequate care, understanding the systemic barriers that there are also those systemic barriers that have prevented Hispanic adolescents from accessing that contraceptive use, or just the lack of information that there is. And so with that, it's also important
to moving forward using this information to target those sexual health education programs, because they are the ones that reach a larger audience of Hispanic adolescents, and so it's important to ensure that they are providing comprehensive education and also ensuring that that Hispanic adolescents are aware of the options that are available to them. Thank you.
Thank you so much, Karina. Question for Karina. Yes, please, Debbie.
I was just curious if the research that you looked at, was there any indication on that spectrum of age between 11 and 19? Like, is there a particular age group in which this issue is more prominent? And did you find anything that suggested at what age should you start this education for adolescents?
This one was more of a review article, so it looked at 16 studies and collected all the main themes that they've noticed across, and it was mostly high school students that they were looking at, and so that's what most of the subjects were. Yeah, thank you.
Yes, please.
Super well done. Could you just expand on what symmetry with mother about sexual health means? It's in the facilitators to contraception and the interpersonal part.
Which one are you talking about?
The symmetry with mother about sexual health. I'm just wondering what that is.
Oh yeah, so that means so similar to Samantha, who had like really open conversations with her mother, it relates to that, just being able to connect with especially the mother, because they are the ones who can provide just more insight on contraceptive use, and just being able to align with those conversations.
Gotcha.
Yeah, because in the barrier, sometimes there's misalignment in which the mother would probably say, oh, just abstinence only, and not really provide that conversation about what options are available.
Great. Well, thank you so much, Karina. All right, our next presenter is Aria Trivedi. And Aria is a senior biology major and biotechnology minor. And Aria's topic is misconduct in your backyard, an ethical review of clinical trials. Aria.
Hi, everyone. So my name is Aria, and I'm going to be presenting on clinical trials and looking at the ethics of them, along with going into a case of ethical misconduct. So first and foremost, clinical trials are really important to advance medicine and bring new life-saving treatments to patients. And they're really useful to test the safety and efficacy of treatments before allowing for general use. In clinical trials, it's really important that informed consent is given this increased risk. So in clinical trials, informed consent looks like giving a basic description of the study, talking about the risks, the benefits, potential other treatments that could be given, compensation, and most importantly, patient rights. So in clinical trials, a big patient right is the ability to leave a trial at any time for any reason. This is really important that patients know this before entering into a trial, and that typically they're also given contact information of who to contact in case they do want to leave the trial. Additionally, it may be important to let the research team know that you do want to leave the trial in case you need to taper off, depending on whatever the treatment is. And additionally, clinical trials typically go through institutional review boards, also known as IRBs, which typically enforce federal guidelines along with potential institutional specific guidelines and oversee the ethical conduct of research. So the Belmont Report is a report that was published that outlines basic ethical principles when dealing with human research participants. So the first is respect for persons. This looks like respecting people's autonomous decisions and also providing protection to those who have diminished autonomy, such as those with mental disabilities. Beneficence under the Belmont Report has two portions. The first is do no harm, and the second is to maximize potential benefits and minimize potential harms to participants and society. And lastly is justice, which is giving each person their need based on giving each person an equal share based on their needs. So now I'll go into a case of ethical misconduct. So this was a clinical trial in Kaiser Permanente of Northern California involving the drug Vascepa, which is a fish oil derived drug. So this study included the 2 leaders of the clinical trials division. And the first kind of ethical misconduct that is seen is having 18 participants participate in the trial who were allergic to shellfish. And this is concerning given that the drug is a fish oil derived drug. And additionally, all clinical trials are listed on the FDA's website, so you can always take a look. And part of the exclusion criteria was excluding people that are known to have allergies or sensitivities to fish or shellfish. And actually, there is like anecdotal case of a patient being in the trial who should not have and having a poor reaction to the drug. Additionally, people with other medical problems such as cancer or those in vulnerable populations were also included in the study, which is pretty concerning given that this violates beneficence since it's putting people that are at increased risk into this high-risk clinical trial. Next, dozens were unduly influenced, so this meant either minimizing potential harms or promising that there's some benefit to the drug, which is the whole point of the clinical trial to test that. And also, many patients were reapproached. So patients who stated hesitancy to joining a clinical trial, the researchers noted that as an opening to recontact people and ask them to come back and join the trial even if they did not want to join the trial. And that shows a lack of respect for persons and people's autonomous choice to not be part of a clinical trial. Lastly, there was unauthorized changes to the FDA-approved protocol. So prior to a clinical trial beginning, not only does the research need to be approved by the IRB, but also by the FDA. And in this case, Vascepa is capsules, but some patients were unable to swallow, so the research team instructed them to open the capsules and take basically the liquid that was inside of them, which is definitely not allowed as it's a new drug delivery method. And so overall, audits, after all this ethical misconduct occurred, found that the IRB did not have enough authority. So in this case, the IRB would ask for more information from researchers, and they would cite confidentiality and privacy and not provide that information, which is also against the IRB guidelines, but points to a bigger issue in Kaiser's leadership in how much authority they give the IRB and how much emphasis they put on the ethical conduct within their research program. And also the FDA found that Kaiser lacked comprehensive human research protection program. So a program like this would oversee and have additional guidelines to make sure that this type of ethical misconduct did not occur. And overall, this case shows many ethical breakdowns, starting from the researchers, but continuing to the IRB, the leadership, and Kaiser's infrastructure, and not having enough safeguards to make sure that research was conducted ethically. And also it was very interesting to see that even when the study was terminated, the researchers are actually still listed on Kaiser's website. Doesn't state whether they're still practicing as physicians or if they're still conducting research, which is a little concerning to see given how much ethical misconduct occurred. Additionally, the study was suspended and terminated, and the researchers agreed with most of the findings, though they stated that the study was misrepresented in certain circumstances, and their appeal to continue the study was denied. So ultimately, from this case, we can have a few main takeaways. So first is to know your right to withdraw from a clinical trial at any time for any reason. Take your time before joining a clinical trial and make sure to ask questions. Keep a copy of the consent form and make sure to read it thoroughly before joining, and report to researchers if necessary. Thank you.
Thank you so much. Arya, question for Arya. Yes, please.
Hi, Arya. Great job. I'm just curious on the level of authority that the IRB has as of right now. And in your opinion, do you think that they have too much oversight, or do you think that there still needs to be progress to where they have more oversight of things like this?
Like the IRB in this case, or general IRBs?
Just in general, in present day.
Yeah, so I would say the IRB in theory is a great idea, but cases like this show when like the leadership does not support the IRB, it's not able to function properly. So in this case, many of these patients did complain, but the complaints never made it to the IRB, given that the researchers would kind of escape and like hide what was really happening. So I think IRBs do have a lot of power and can be really helpful to prevent ethical misconduct. But if the institution and leadership doesn't give enough power, they can't really do their job.
Thank you. All right, let's give it up for Aria. All right, our final presentation tonight will be by Yesenia Andrea Sandoval. Yesenia is a junior biochemistry major and biotechnology minor, and her topic is integrating spiritual health into holistic patient care, ethical perspectives on Hispanic mortality paradox. Yesenia.
Hi everyone, my name is Yesenia, and today I'm going to be talking about spiritual health and its implications on the Hispanic mortality paradox. To begin, I don't know about your guys' social media, but I know on mine, people are constantly trying to promote how to live longer and healthier lives, and additional lives at the end of your life can be really important. It could mean the difference between watching family members graduate, watching maybe people get married. So I thought it would be really important to conduct a case study on my community, on the Hispanic community. So first, in order to understand why I chose the Hispanic community, first we must understand some demographics. To start us off, Hispanics make up about 19.1% of the United States population. About 16.8% of them are uninsured, 73.1% have high school diplomas, and 20.4% have college degrees. Amongst these college degrees, it includes bachelor's and graduate degrees. And to put these numbers a little bit into perspective, comparing them to non-Hispanic whites, about 95% of them have their high school diplomas and about 39% have college degrees, making it like pretty significant. Other disparities that the Hispanics face are they have higher rates of unemployment, and the average median household income is about $20,000 less than the average non-Hispanic white. However, again, why is this all important? Because despite all of these disparities, Hispanics still live longer than most Americans. So I thought it was really important to kind of like look at this and kind of look at the role of spirituality and religion on this community and how it implicates them living longer. So first of all, what is the Hispanic mortality paradox? As I explained earlier, it's where Hispanics tend to live longer despite facing disparities. To give a kind of perspective, Hispanics lived around to the age of 80, whereas non-Hispanics live around to the age of 77 on average. There are two current theories to explain this paradox. The first is the Salmon bias. This is typically where immigrants tend to move back to their home country when they retire, when they're in need of a job, or when they fall sick. The second explanation was the healthy migrant hypothesis. This is where only healthy immigrants are able to fully transition to America and make a life here. And I thought these two are important to note just because they're just explanations, as neither provide a full explanation as to why this paradox occurs. So I thought it would be nice to offer a third explanation through the exploration of spirituality and religion and how that is implicated amongst the Hispanic community. So first, in order to understand spirituality and religion, we first must understand its role in holistic medicine, which emphasizes treating the whole person. Holistic medicine, like I said, treats the whole person, but looks at ethical, familial, social, and societal values. But amongst these is also spirituality. In the Hispanic community, spirituality and religion are often practiced together and are seen to have positive health implications. And about 72% of Hispanics report to have a religious affiliation. I didn't go into specifics because none of the research I did went into specifics. And to kind of look at the role of spirituality and religion and these positive health implications, spirituality was linked to better cognition, better lower death rates, and better self-reported health amongst patients, and religion was seen to tie to lower stress and better coping mechanisms when receiving care. But spirituality and religion together increased feelings of faith and hope amongst their patients. However, what did this mean for healthcare? In my research, I found that in 2015, the American Medical Association finally acknowledged that spirituality should be incorporated into care. This emphasized that there was an American cultural gap in our society that kind of hesitated bridging this gap in education and bringing this into our healthcare system. Currently, to this day, 41% of Americans say that they would rather not talk about religion or spirituality to avoid any disagreements, especially with discussing in care. Even some of the principles we understand today, like the ethical principles we learned in class, beneficence, autonomy, non-maleficence, and justice, often are only interpreted in a secular way that don't really look at spiritual health. In 2018, the AMA released a guide on how to talk about these practices in care if they're being brought up by their patients. This further emphasized that physicians have a duty to kind of take into consideration a person's overall well-being, including their spiritual health. It also further acknowledged that if these conversations are continuing to lack, it could hinder a patient's autonomy because it cannot fully express themselves, especially if religion is a big tie to like their identity. I also saw in some research that these discussions are still being largely neglected in our care, and patients have actually seen negative outcomes because of it. It's been detrimental to the quality of care that patients receive. Some reports say that it's even led to them like starting to distrust their physician-patient relationship or even our healthcare system that we know today. This is again, very important because this violates the ethical principle of non-maleficence, which is to do no harm, and like breaking that physician-patient trust is super important, and especially like making sure that there's trust in our system. But what does this mean for the Hispanic mortality paradox? The Hispanic mortality paradox highlights this gap in our education and training that physicians receive, as well as highlighting the integration of spirituality could fight ongoing health disparities even amongst other communities. The ethical principle of justice begins to highlight how every patient deserves equitable, patient-centered care, including these conversations of spirituality and religion. However, what are some key takeaways? Some key takeaways are to establish trust, openness, and focusing on the whole person, including spirituality and religion. Physicians have an ethical responsibility to kind of look at these conversations and see where they can integrate them into care if they seem that it's appropriate, as well as a change in attitude of our healthcare system to create a culture of more respect that make these conversations more comfortable, as well as the role of spirituality and religion and its implications on our health, and looking at the Hispanic community to kind of be a case study of that to prove that. Thank you.
Thank you so much, Yesenia. Question for Yesenia. Please.
So my family's from Argentina, and we're like very Catholic, and I know a bunch of people in the Hispanic community are also very Catholic as well. Do you think that that plays into effect on health outcomes at all?
I think religion overall, none of the research I looked at was really religion specific. I did include a statistic of 72% of Hispanics report religious affiliation, but to put that into perspective, it's 67% plus are Christian and 5% are other or other religions. So I guess since majority of them identify as Christian, you could kind of say they have that plays a bigger role in their lives. Since we could kind of play more into that.
Great. Well, thank you so much, Yesenia. Let's give it up for Yesenia. And let's give it up for this amazing crew of students and all these wonderful presentations. Whoa! Yes, great job. Really a fantastic job. And I just think it's important for us to sort of slow down and think of all the hours each of them spent, all the hard work and time reading, thinking, clarifying, figuring out slides, pruning things down to 7 minutes. We had no problem. It was just everyone was like clockwork. But to do that, I know it takes so much time and effort, and really appreciate it, and being willing to stand up in front of us all and kind of lay it on the line and say what's on your mind and heart. Way to go, everybody. We totally appreciate that. Yes. I would like to now, in closing this wonderful evening, turn it over to Sydney, who's got a few last words for us, and then you're on your way, everybody.
Yes, I promise I won't keep us too long. I know we've been in this room for quite a few hours, but I'm so proud of all of you. Dr. Caminti is so saddened that she cannot be here tonight, but I spoke with her this morning, and she just wanted me to reiterate to you all how immensely proud she is of every single one of you, the work that you have done this year, the effort that you have put into your blog presentations, but our class overall. Seriously, it's quite an accomplishment to have gone through the class, every single Monday for 2 hours coming and sitting in class and doing reading and being prepared and doing your shadowing. So it definitely is a big effort, and you should feel very, very proud of all that you have accomplished this year. And so we're just so proud of you. I did just want to give a quick thank you to the team at the Markkula Center as well. If we could give a round of applause for them. Thank you to Dawn Hyder, who's the director of the Markkula Center, but specifically to Joel and Debbie for all the work that you do. They read all of your blogs. So yes, they deserve a round of applause. So thank you for all of your continued support with all the marketing needs, but also helping us to publish all those blogs every single year. Thank you to Monica, who is our event organizer queen. Everything that I feel like we ever need, she just immediately has it and has it taken care of. And so thank you for all of that. That does not go unnoticed. And thank you, Dr. DeCoste, for stepping in this evening and helping to lead this event. Definitely, we really, really appreciate your time. I know it's quite a couple hours, so we appreciate you taking the time on your Monday evening. So round of applause for him as well. As a closing, we always want to, represent and shout out the new Hansel Fellow for next year, who's going to be Maria. So give her a round of applause. It is going to be in great hands with Maria, so just want to say congratulations to you. And just another overall congratulations to all of you, all the work that you have done. We wish you nothing but the best in the future. You all have very, very bright futures ahead. And so, but that is the end of our program tonight. Thank you all for coming out, and I hope you have a good rest of your week.